No, I didn't. But I did, I did suggest it, we decided that I would stop you guys from studying that on your own.
Hey, what? The whole chocolate?
No. There's 7 slides, 36 slides. You will have 2 questions, similar to the last 2 that you had for bonus, off that lecture on pharmacology and short. I will ask you, given the, you've got these 2 endings, name the class that it goes with and name 1 drug from each class. Okay? I'm promising you that. I was asked a question here about studying an alternate location. We're all going to have to do one thing or another. You can go study in an alternate location or this thing. If you want to go study in an alternate location, I'll go hush because I got 50.
We'll go study an alternate location.
Is that what everybody wants to do?
Yeah. We'll all read the chapter.
Okay, how many people want to go study elsewhere? 5. 6. Was that a vote, Savannah? Okay, that's 7. How many people want to stay and review? 1, 2, 3, 4, 5. Guys, you're outvoted by 2. Okay. You want me to go for 10 minutes and stop? Okay, think of that. On number 1, what I'm going to do is give you questions about a certain kind of unit, a certain style of pneumonia, like left lobe, right lobe, upper lobe, bilateral, something like that. And then I will ask you, what is the most likely diagnosis? Now, with pneumonia of any kind, if I'm not saying that there's tracheal deviation of some kind, you're just there with pneumonia. So with pneumonia, you get air in and out. Yeah, but what your problem is that things are glued together, so your what is fouled up. What diagnostic? Exchange, gas exchange is fouled up. If it says something about he has tracheal deviation, or that the guy has got an apricot caught stuck in his throat, then it's infected airway infections. But other than that, when you see one of these things, if it's not otherwise specified in its lung, think gas exchange. If there's anything to go with gas exchange, and it doesn't specifically mention the airway. Okay. Everybody knows what the WBC is, white blood cell count, CBC, complete blood cell, and that's the overall test that show WBCs. EBGs are gas. Your electrolytes normally tell you about potassium, sodium, chlorine, and so on. Serum creatinine tells you about kidneys. PTT tells you about heparin. And serum potassium and serum K, you're not going to get all those. How do you help a patient clear their airway? Cough. And when they can no longer cough alone, Hyperlink. Okay. Now, the Hyperlink is gone, the patient passes out, it didn't come out. You continue to try to get their airway clear with chest compressions. Okay. Can everybody name a whole bunch of risk factors for lung cancer?
Smoking.
Is a big one. Asbestos, anything that you inhale chemically. Okay. How about radiation? Radiation is a risk factor because when you irradiate things, that means you're arrested. How do we use it to treat lung cancer? We literally irradiate it to death, and it's good only when the lung cancer is in one spot. What's pleural effusion? Pleural effusion is water flow between the sacs and the lung. And since you've got water pressing in on there, it makes the lungs wet, and it makes it harder for them to expand. Goodness, 7 doesn't make sense, or something missing. Describe that to the phone. Okay, how would you treat pleural effusion? paracentesis. Okay, you send a patient home who's got a diagnosis of asthma. What should he learn about it? How's it triggered? You should know about the emergency buffers, right? And you should have a follow-up schedule. Once you come back, you may go home with a pulmonary function and with a log, so we can help keep up with symptoms. Okay, so he's been doing this for 3 months, and on routine follow-up visits, what you expect him to be good. Now, if I gave you a list of adrenergic drugs, which one of these is an adrenergic bronchodilator? Formalin sodium, Asmacort, Tylate, or albuterol. Now, albuterol is the only one that's an emergency inhaler. The other 3 help to control symptoms, but they're no good in an emergency. Prophylactic is a good word. Okay. How would you describe airflow in a patient who has emphysema? What causes emphysema? Spasm in the smooth muscles? Asthma. Emphysema, damage alveoli and air traffic. Maybe. Inflammation with increased mucus and presence of infiltrating alveoli. Damaged alveoli and air traffic. Because emphysema, think of emphysema as pus. You get pus down in there, it dries out and sticks everything together. Why do we use corticosteroids in patients who have COPD? Decrease inflammation, pure and simple. Now, please, corticosteroids know the 6 things it does, 3 that it does that it increases, 3 that it decreases. For instance, it increases blood sugar, increases water weight. But there's 6 of them, okay? Okay, you've got a patient with COPD. Your limit on O2 administration should be about
2 liters.
2 liters. Okay, what is the level of the oxygen? Say again?
10 to 20.
10 to 20. Okay, so if it's high, he's
21.
too much, and he's going to overdose, right? Now, it's a bronchodilator, so if you overdo the bronchodilator, you get a reverse, and you can cause bronchoconstriction. It's a big value. Okay, what do you do in order when you enter a room with a dyspneic patient? I'm laying in the bed, I'm laying flat, I'm gasping, I cannot breathe. Sit me up. Then,
O2.
put the O2 on me. Then,
Monitor again. Call nurse. Tell somebody.
call for help. Do you ever leave me alone?
No.
No. Because when I'm oxygen short, I'm already panicking. What do you teach for the drugs you got? Yes, this is cat on the rope ranges, but it will cause bronchodilation unless you get too much. When you're taking treatment, end-stage COPD, cortisone is to remove the inflammation. Demerol is for pain. It is an opiate. Morphine for pain is an opiate. What is propranolol? The hypertension, it is a what kind? OLOL. It says cardiac specific beta blocker. So you can use it with a lung patient safely, right? Good. Okay. Everybody know your norms for ABGs? I'm going to ask you to interpret the things and say, what have you got? Respiratory or metabolic acidosis or alkalosis. Real simple. If the CO2 goes one way and the pH goes the other, one goes up and the other goes down, say the pH goes down, CO2 goes up, that is respiratory acidosis. They go opposite directions. If they go the same direction, both go down, it is metabolic acidosis. So it's acidosis if it's below 7.35, Alkalosis if it's above 7.45. Savannah looked almost panicked. Okay. What do you expect of a COPD patient who needs O2 to ambulate to the bathroom? How do you know that it's been successful? I write my nurse's notes or my care plan. The patient will be able to ambulate safely to the bathroom without additional O2. So how do I know I've been successful?
Check it out.
They go to the bathroom and back without O2 safely. Okay. Everybody remember cystic fibrosis from today?
Yeah.
Big thing is sticky needles. Gets into the lungs primarily, also gets into the digestive tract, and because it blocks all of the small tubes, all of the enzymes we use for digestion out of the pancreas are usually locked up in the pancreas and can't get out. So we have to add those enzymes. The big kick is keep the mucus thin, high salt, high energy. Get the mucus out of the mucus. Major risk factor for respiratory dysfunction is smoking. How do you assist a patient with a weak cough and thick secretion? Hydration and say again? Cough and deep breathing. You want to give mucolytics to loosen the sputum and an expectorant to encourage coughing. Okay. Hemoptysis is what? Bloody.
Bleed.
No.
Emesis.
It's not sputum. It says hemoptysis is
blood in the.
colon. So bloody vomit. Hypoxia. Too much CO2 in the exhale. Hemoptysis. Bloody sputum. Hypercarbia. High CO2. Or CO2. Describe these skin tests. Everybody knows how to do the skin pop? There was a little box in there that said, if it is so big, the person has the following history of positive. Know that box and apply. What does the kidney skin test do?
It'll make you a copy.
Okay, it's the kidney skin test is over with the kidney skin test. It's a control. Okay. What risk factors for TB?
No.
Everybody feel comfortable with that?
Yeah.
What are the drugs used to treat TB? Mifenyland and INH. Your TB patient is in respiratory isolation, must travel to an X-ray. What do you put on before you go? Surgical mask, even though it's not totally effective, it does help some. How long does drug therapy for TB generally last? 6 months, unless it's from the resistance. Why is it necessary to continue treatment even after active symptoms have passed? Decrease the symptoms, but the drug or the bug's still alive in you, right? What are the risk factors for TB? If you discover a patient that you suspect of having TB, what do you never do? Outpatient or the test for it that we never do is open sign. What methods do you use to test people? D-dimer tells you there's a clock somewhere instead of taking where.
That's not medicine, though. Is that what meds are used?
I should have said test.
Yes. Okay.
Okay. What do you do when you pull a chest tube? Okay, it's got to be dressed with Vaseline gauze and plastic cover to make it airtight. You're listening to the lungs of a patient with a pneumothorax. What do you hear? diminished or no breath sounds. If they're diminished, then it's going to be an echo to it. If you have respiratory failure, how does that affect a patient's pH? Does it go up or down? Down when he comes to sit. If he's not breathing, he's not blowing off CO2. CO2 is the same as acid. Following thoracic surgery, what you watch for? Thoracic surgery, always got chest tubes. So you're watching for idling in the center chamber and no bubbling. You don't want it to bubble in the center chamber. If it does, there's a leak. Okay. How do you evaluate gas exchange in end-stage COPD patients? How do you prevent lung cancer in general? Don't smoke. The most common cause of death from infection is smoking. Okay, your patient's candida test is positive, their PPE is positive, therefore you interpret the test as meaning they have TB is present in their body. The most common form of pneumonia is
Bacteria? Bacteria, hospital acquired pneumonia. Hospital acquired pneumonia. From surgery. Not later.
now if it's nosocomial, which one is nosocomial?
Hospital acquired.
Okay, and what is the name of that particular beast?
Bacteria.
It's bronchopneumonia.
Hey, I had it right.
Okay. Okay. How does these fog reflect severe long-standing bronchiectasis? Low-grade fever, you've got infection, copious sputum. That's what caused the whole mess to begin with, distended neck veins, fluid backing up into the heart, dependent edema, and black-side failure, periodic episodes of harsh coughing. Your body's trying to clear the thick skin and can't get it out. The biggest killer worldwide of children and adults is blank. No.
What? Killer worldwide. Cancer.
No, I think it's TB.
That really you learned something about TV and the show.
Yeah. TB is the biggest worldwide. It's the biggest killer. Not in the United States. Okay, know your labs. Please review your labs.
Okay, that was the thing.
Okay, 45
I thought you didn't want to stare at me for like 20 minutes, so I put the pillow in there. But there you go. This is the only way I can figure out how to upload it. So, good luck.